certain interesting topic, particularly the hemorrhage in pregnancy, hemorrhage during pregnancy, and the maternal deaths are mostly caused by hemorrhage. And hemorrhage may be during the antenatal period, that is the APH, maybe the postnatal period, that is post immediately after delivery of the baby, third stage postpartum hemorrhage or postpartum hemorrhage. And earlier pregnancy also there may be some hemorrhage. About 30% of the death, maternal death occur till due to the hemorrhage. And other causes, all of you know, that is the hypertensive disorder, that is very important. There is preeclampsia, and other is the sepsis infection, and other so many causes, but these are the three main direct causes. One is the hemorrhage, second is the hypertensive disorder, and third is the infection. And from last 30 years, actually maternal death has been dramatically reduced, not only in global but also in India also, due to the prevention and taking care. So today I just start with a just history. A patient, primary gavita, woman at 34 weeks of pregnancy has come to the emergency with bleeding per vagina. What is it called in obstetrics, and what is your diagnosis? How would you manage? So what is it called in obstetrics? It is called antepartum hemorrhage. It is the antepartum. So today's topic I will cover the antepartum hemorrhage. And how will you diagnose? There are main two types of antepartum hemorrhage. One is the placenta previa, and other is the abruptio placentae. These two, and if you will have to diagnose these two, how to differentiate diagnosis, because both are dangerous, but management is different in both sides. Management, and both now actually the abruptio placentae, accidental hemorrhage, is more dangerous. Accidental hemorrhage is more dangerous than the placenta previa. So I will first, how will you define in the antepartum hemorrhage? Common question. If the long question is come, the first question may be come. Probably last exam it was given. Antepartum hemorrhage is defined as the bleeding from or into the genital tract, during pregnancy after the age of viability, after the birth of the baby. After the age of the baby, and early month, there may be early month pregnancy also, and till up to the birth of the baby, starting from the age of viability. The age of viability actually differs from country to country, because it was previously it was 28 weeks, but now standard international age of the baby, gestational age is 24 weeks. And in some countries that like USA, it is regarded as 22 weeks. The baby may survive after 22 weeks. But standard is the 24 weeks, the age of viability. Antepartum hemorrhage, that means it may be during the antenatal period, before the onset of labor, and also the first stage and second stage of the labor. So it's strictly not only antepartum, it is the antepartum and intrapartum also. Intrapartum is the three stages: first stage, second stage, and third stage. First stage means from the onset of labor to the full lactation. Second stage means full lactation to the delivery of the baby. Third stage is the placental delivery. So first two stages are included in the antepartum hemorrhage, and the third stage and after the delivery of the placenta, the hemorrhage which occurs, that is postpartum hemorrhage. So antepartum hemorrhage is strictly not only confined to the antepartum period, but also the first stage and second stage of the intrapartum period. Be clear. The causes of the bleeding during pregnancy. What are the causes of this? This is the common question. First question, it is asked and also given in the exam also. Abortion of the miscarriage, that is the when the age of till the age of the viability. Abortion and the miscarriage. That will be different types of abortion. Take another class on abortion. Very interesting thing. And antepartum hemorrhage from age of viability till the delivery of the baby, and postpartum hemorrhage after delivery of the baby until the end of the puerperium. The amount is such that it threatens the hemodynamic stability. Bleeding after postpartum hemorrhage, bleeding after delivery, after placental delivery, there is some bleeding. That is actually the lochia rubra bleeding. But if it deteriorates the condition of the mother, when if the amount is more, or if the patient is already compromised with the anemia, that may also the deteriorate the condition of the mother. So that is the postpartum. And the definition between the antepartum hemorrhage and postpartum hemorrhage is that any bleeding during the antepartum period is abnormal. Always. But postpartum hemorrhage, you see from the definition you see the end of the puerperium, an amount, quantify, which deteriorates the condition of the mother. That is the basic difference of the antepartum hemorrhage definition and the postpartum hemorrhage definition. The causes of the bleeding in early pregnancy is the abortion or miscarriage, and another thing is the H mole. The specimen is there, you will see, and also the ectopic pregnancy and other. These three, the most dangerous is the ectopic pregnancy, because ectopic pregnancy bleeding is big, but the interperitoneal bleeding is too much, interperitoneal bleeding. Causes of the antepartum hemorrhage. What are the causes? I have already said in beginning, in the placental membranes. In the placental membranes, that is the Placenta Previa, another is the Abruptio Placentae, another Vasa Previa, and also the Vasa Previa. And next is the other indeterminate cause. Cause is not known, that is bleeding. And very uncommon cause, but the patient is a woman, that may be gynecological cause, such as the cervical polyp, cancer cervix, and also varicose vein of the vulva, that may mimic the bleeding like antepartum hemorrhage. This is actually other causes. And placenta previa, what is the placenta previa? This definition you see, that is very important definition. You see, the placenta previa is when the placenta is situated partially and completely in the lower uterine basement. That is, here placenta situated partially and completely the lower uterine basement. Normally, the placenta lies in the fundal region, and after, if it is implanted in the lower uterine segment, there are some causes why lower uterine segment occur. Normally, not. That is called placenta previa. Literally, previa means in font. And why bleeding occurs placenta previa? Because there may be placenta is lower uterine segment. If there is some onset of labor, even before onset of labor, there is the separation of the placenta and the uterine wall, there may be bleeding. That is the bleeding in the antenatal period is not so much. That's something the warning symptoms. But later on, during pregnancy, during the labor onset or more term, there will be severe bleeding, antepartum hemorrhage, placenta previa. Now, abruptio placentae. Abruptio placentae means placenta normally situated in the normal position, that is the fundus. And before that, what happened, there is the premature separation of the placenta. What will happen? The premature separation, if there is a premature separation, what will happen? There you can see the premature separation of the placenta, and placenta is upper uterine segment. So there will be the bleeding just beneath the placenta, uterine, and so that may be concealed hemorrhage. May not come out. So patient, there is bleeding, but you see the tachycardia, features of the pain, and also the features of the pallor. You will see. That is the Abruptio Placentae. And the term accidental hemorrhage is popular. It gets written different terms. Abruptio placenta, accidental hemorrhage, placental abruption, abruptio placenta. The Latin word, the abruption means the breaking away. Now, so you can differentiate. One is the normally situated placenta, separation, abruptio, and another is the placenta in lower uterine segment. Risk factors for the placenta. Why disease occur? The scarred uterus. Suppose what happens, small uterus, the early pregnancy. So there is a scar. Normally the migration of the placenta occurs, and when the uterus becomes enlarged, the placenta goes to the upper uterine segment with the enlargement of the uterine cavity. But sometimes, suppose there is the scar, the caesarean scar, and the myometrium scar, the placenta cannot migrate. So that is one of the important reason, and that is the previous caesarean section. Even that is also the adherent also, morbid adherent of the placenta or placenta accreta. So this is more dangerous. And sometimes, suppose the multiple pregnancy, there is a large placenta, 2 placenta, and even in the triplet pregnancy, there will be 3 placenta. So the large area will come from lower uterine segment, that may cause. That is and placenta membranosa. Membranosa placenta means placenta membranosa hold the placenta. Placenta, what happens after when if you go to the development of the placenta is a part of it goes to the placenta, and other part becomes the membranes, and that is the amnion and chorion. But what happens in placenta membrane is the whole of the membrane becomes placenta. So that is the large placenta, but not so effective. And sometimes the assisted reproductive technology, it is seen the placenta is high. Risk factors of the abruptio placentae. One of the risk factor, any patient, the hypertensive patient, preeclampsia, hypertensive patient, there is a preeclampsia, there is a chance of abruptio placentae. And trauma, outside trauma, and sudden decompression of the, suppose there is a hydamnias, and just membrane rupture, sudden decompression. So there is a separation. Premature rupture of membrane. Is it visible? All of you? Is it visible? It is not obstructing. You can come also there if there is a problem. Is it visible? So, and the premature rupture of membranes, that we also call the abruptio placentae. Now, Vasa Previa. Vasa Previa means, what do you mean Vasa Previa? That is Vasa in the lower part. But what happens in case of, suppose the cord may be normally inserted in the umbilical cord, in the placenta, and around the placenta, middle point of the placenta, not always middle point, but placenta. But sometimes it may inserted in the membrane, and that, so the cord has to pass through the membrane, and that if that membrane covers the placenta, that membrane covers the internal os, what will happen? The vessels will come into the internal os. So when there is an onset of labor, particularly the onset of labor, if the vessels rupture, that bleeding, actually that is the fetal bleeding. So fetal will be exsanguinated. And you will have to remember these are the three types of mainly. One is the placenta previa. In placenta previa, who bleeds? Is actually maternal bleeds. In abruptio placenta, also the maternal bleeding. But Vasa Previa, that is the fetal bleeding, Vasa Previa. That is the Vasa Previa, and when the cord inserted into the membrane, that is called velamentous insertion of the placenta. It is called the velamentous insertion of the placenta. And in placenta previa, the mother bleeds, but in Vasa Previa, bleeding comes from the fetus with high fatality of the fetus. And there are some tests, the Klehart test or acid dilution test, alkaline detergent test, how to detect the fetal blood, and detect whether it is the fetal blood or the fetal blood. These sort of sometimes come in the exam. So, now come to the types of the placenta previa. Recently, it has been so more simplified. Is the type 1, type 2, type 3, type 4. Type 1, type 3. This is the previous classification. Type 1 means you can see the type 1, you can see the low-lying placenta, that is the type 1, low-lying placenta, not into the internal lobe, and type 2 the marginal, not covering the internal lobe, not covering the internal lobe, and type 3 is covers the internal lobe partly, and type 4 is the total internal lobe and lower uterine segment. So these are the 4 classical types. But recently, to make it more simplified, so clear type 1, type 2, type 3, type 4. Sometimes the type 2 is called the dangerous placenta previa, because if the placenta lies posteriorly, the head cannot engage. So it cannot engage. So there will be excessive bleeding. There is no pressure. That is, sometimes it is called dangerous placenta previa. The type 2, previously it was called. Recently, the classification has been changed, NIH classification. The placenta previa, the internal lobe is covered partially or completely by the placenta. And the low-lying placenta is implanted in the lower uterine segment, and the placental margin does not cover the internal lobe, but within 2 centimeter, does not cover. That is the low-lying placenta. And so you can see the type 3 and type 4 is the actually placenta previa. Now said a low-lying placenta is actually maybe the lower uterine segment, but it will be in the 2 centimeter within. It may be near the internal lobe, it may be the more to the internal lobe, and that is the but within 2 centimeter. This is the latest classification. Placenta previa, you can see on left side, this is the complete placenta previa, and this is the low-lying placenta. This is the modern definition. And abruptio placentae means the reveal type, I will say, and the conceal type. Reveal type means the bleeding is coming. You will know there is a bleeding. But in reveal type, the conceal type, there is no bleeding, internal bleeding. That is more dangerous. As the placenta becomes separated, it is more dangerous to the fetus and also to the mother, but because there is a chance of DIC, distributed intravascular coagulation, and renal failure also. Hypertension, internal bleeding, and DIC, hypertension is the preeclampsia, DIC, and that may cause the renal failure. So these are the abruptio placentae, and you can see that there is a retroplacental clot. You can see the retroplacental clot. This is the retroplacental clot. I will show more pictures also for you to remember. That is it is a cesarean section after the delivery of the placenta. There is a huge retroplacental clot and bleeding. They are bleeding. And diagnosis, bleeding and its pattern, general examination, that is the general examination, pallor, pulse, BP, obstetric examination, per abdominal examination, vaginal examination, and sonography. Don't do vaginal digital examination. That is the learning important point is, don't do in the antepartum hemorrhage PV examination. If you do the PV examination, what will happen? There will be stimulate for the more bleeding. You do not know it. That may be placenta previa. If there is a touch of the finger, there will be excessive bleeding. So only inspection you say how much bleeding is there, the vaginal examination. That is here said only inspection, no bimanual examination. And sonographical diagnosis. And diagnostic features of this is very important. How will you differentiate what is the placenta previa and what is the abruptio placenta? The pattern of the bleeding. In case of placenta previa, there is no cause. Patient is working in the home or like that, no cause. Painless, recurrent and always reveal, always reveal. But in abruptio placenta may be associated with pain, concealed or revealed, dark shaded color. And pallor or gel examination, there is the proportionate to the bleeding in case of placenta previa, proportionate to the bleeding. In case of placenta previa, there is the proportionate to the bleeding. Is it visible actually? Okay. Proportionate to the bleeding, but abruptio placenta is out of proportion. That may be the concealed bleeding. And features of the preeclampsia, placenta previa usually not, but abruptio placenta there will be common issue. Another problem that may also the eclampsia also. And height of the fundus correspond to the period of amenorrhea, here, but here as there is a concealed hemorrhage, so the height of the fundus. So when a patient comes to the emergency, any appendectomy make a mark with the pen color, the height of the fundus. And palpation of the uterus, that is the soft and relaxed, but here is a tense tender, and presentation, more chance of malpresentation. As there is a lower uterus segment, there is a lower uterus segment, as there is the placenta, so head cannot engage, so there is a malpresentation like breech, or commonly the breech is even the transverse line. But here there is no problem, usually vertex and engage. Fetal ultrasound present and abruptio placentae, as there is a retroplacental clot and a separation, there fetal ultrasound may be there. So baby is more, if some you explain why the question come, the baby in case of abruptio placentae is more vulnerable to die than placenta previa. What is the explanation? Simple explanation. There is a retroplacental separation, and you are not able to see how much the bleeding is there. So baby can die. More vulnerable baby. The abruptio placentae is always dangerous than the antepartum hemorrhage. The height of the fundus, you see, the height of the fundus is the more than the period of amenorrhea. Height of the fundus is major. Height of the fundus. Don't do external digital examination in antepartum. The cross syndrome, don't do. That is the cross. Ultrasonography can diagnose the lower single placenta, and ultrasonography in case of abruptio placenta, there will be retroplacental clot. Sometimes it is difficult to diagnose the abruptio placentae until unless there is a good resolution of the machine. So, but can be diagnosed both. And placenta previa, it is you will see in the ultrasonography plate in exam, you will see the, probably some of you have faced the ultrasonography plate in the exam, the placenta previa ultrasonography. And dangers of the placenta previa. Now come hemorrhage, both, and shock. And shock is proportional to the bleeding, amount of bleeding which is seen, and increased operative interference, because placenta previa, as the placenta is lower segment, is always cesarean section. But abruptio placenta, there may be chance of the vaginal delivery, more chance of the vaginal delivery. And postpartum hemorrhage, in both case of placenta previa and abruptio PPH chance basic. Retail placenta due to increased surface area and morbid adhesion. Sometimes the placenta may be due to the scarred uterus, there may be morbid adhesion. Now, degree of abruptio placentae, that is, the dangers of the abruptio placentae, dangers. The same, first is the hemorrhage, and second is the shock. Hemorrhage may be in the antepartum hemorrhage, or also later on the postpartum hemorrhage. And shock may be disproportionate, with the amount of the bleeding visible. And that is more important, one of the important is the coagulation failure. Coagulation, there is a question, is the theoretical part is how the coagulation failure occurs in case of antepartum hemorrhage. Any bleeding, there may be coagulation failure. Abruptio placentae is the commonest cause of the DIC in obstetrics. And acute renal failure, I have already said, acute renal failure, and fetal death. And as it is also associated with the preeclampsia, that may cause the eclampsia also. What happens is actually in practice, suppose a patient has come, you see the pressure is low because the bleeding pressure is low, normal or low, hypotension or normal. But is actually, if it is actually the abruptio placentae and the cause is the preeclampsia, at that time there is a hypertension. But as due to the bleeding, there is a blood pressure fall downs. So that will misguide you. I will say one of the experience of the case in the last. That may be misguide you. So you said the bleeding is there, the blood pressure is normal, so it is antepartum hemorrhage due to placenta previa. But already the patient has bleeding, so there may be hypotension, or that hypertensive patient may become normotensive. And the cuvular uterus, this is a very important thing. Have you any idea who can say, know about the cuvular uterus? Just হাত তোলো, কেউ জানো cuvular uterus কি? না জানলে কোনো অপরাধ কিছু নেই। জানিস কি তোরা কেউ? cuvular uterus জানিস না। এই যে ব্লিডিংটা হয় অ্যাব্রাপসিয়া প্লাসেন্টিতে, তাতে কি হয়, এই ব্লাডটা পার্কুলেট করে টু দ্য মায়োমেট্রা, যার জন্য ইউট্রাসের চেহারাটা এরকম হয়ে যায়, ইউট্রাসের চেহারাটা এরকম হয়ে যায়, কুবেলিয়া, এই কুবেলিয়ার ইউট্রাসের চেহারাটা এই যেরকম হয়ে যায়, ডার্ক পোন হোয়াইট কালার, কুবেলিয়ার ইউট্রাস, দ্যাট ইজ কল কুবেলিয়ার ইউট্রাস। কুবেলিয়ার ইউট্রাস দেখবি তোদেরকে এখন তো তোরা একটু ফ্রি হয়ে যাবি, ধরো ওই যে 64 pioneers of the obstetrics and gynecology throughout the world, there is posters there, posters in your department, কোনো কলেজে নেই এরকম, আমি এটা তোদের শেখার জন্য লাগিয়েছি, দেখবি who was Kobilar, how did you discover everything, and the Leopold maneuver, who was the Leopold, হ্যাঁ এই শোনা যাচ্ছে, আচ্ছা, this is the Cuvelier uterus, short note পড়ে, but Cuvelier uterus is not indication for cesarean section, not indication for hysterectomy, not indication for hysterectomy. Cesarean section, after cesarean section it is seen only during the cesarean section, but it is not indication for cesarean section. Sometimes uterus may be atony, but uterus usually contracted. That is not indication for obstetric hysterectomy. This is the Cuvelier uterus, this is the posterior surface, and this is the interior surface. The lower part you can see, lower part is the cesarean section scar after the delivery, and this is the posterior surface. How does it, sir, আমরা তো নর্মাল ইউটারাসই দেখিনি, সিজারিয়ান সেকশনে নর্মাল ইউটারাসটা আইডিয়া করতে হবে, দিস ইজ দ্য নর্মাল ইউটারাস, দিস ইজ দ্য নর্মাল ইউটারাস, there is not blackish and bluish, deep bluish, dark punctuate, this is the normal uterus. So this is the difference between the Cuvelier uterus. And Abruptio Placentae conceal type is dangerous than reveal type, and in Abruptio Placentae both mother and fetus are danger. However, chance of fetal death is more in Abruptio than in the Placenta Previa, and Placenta Previa is dangerous for mother, not for the fetus. And in Vasa Previa, chance of fatality of baby is high. Vasa Previa, I have already said, Vasa Previa, the rupture of the vessels, the chance of fatality of the baby is high. Mother is relatively safe. And the problem is the Vasa Previa is that it is very difficult to diagnose the pregnancy before the onset of the labor. Very difficult to diagnose. Management of the Placenta Previa. Some of the management. I am summarize the management actually before going to the actual management. In Placenta Previa, usually the antenatal period there is small bleeding. So that is warning hemorrhage. That is called warning hemorrhage. That is warning hemorrhage. But if there is too much early in pregnancy, that is 32 weeks, 33 weeks, bleeding stops usually, and there is a chance of conservative management till the fetus becomes mature, till the fetus mature. This is the more chance of conservative management is the Placenta Previa. That conservative management is known as the Johnson and Macafee regime. Johnson and Macafee. This short note is given in the exam. APH, PPH is very important for your exam, and PPH, your senior batch done, I did ask them to do a PPH deal. They have done very well, and I expect all of you will some deal, the PPH deal and eclampsia deal, who tell me some of students, that is very effective. And PPH throughout their exam, the PPH questions come. And PPH, APH, eclampsia, these are very important. And Abruptio Placentae, what happens in the management of the Abruptio Placentae, as there is a premature separation, so very dangerous, there is a chance of death, usually conservative management, except in mild retroplacental hemorrhage, Abruptio Placentae, conservative management has no role. In some patient can be done, and majority will have to terminate the pregnancy to save both the mother and the baby, depending on the os. If the os become dilated, patient already liver, ARM syntocinon, oxytocin and ARM, that will deliver. The management of the Placenta Previa, admit the patient, and resuscitation, make IV channel. Any hemorrhage, make IV channel. Now there are patients, you go indoor round, and you will now interns are there, how to give the IV from the student life, you know, the interventional channel, how they made. Blood diffusion is done, blood diffusion, grouping, investigations, that is the complete hemogram, how much bleeding, and the coagulation profile, and arrange for sonography. expected management, that is the known as, that is the important sort of the Macafee and Johnson regime, that is the Johnson Macafee regime. And the bleeding and the channel made and blood transfusion when active management, কখন তুমি যে কোনো প্লাসে অ্যান্টিপার্টাম হেমারেজে ধরো একটা পেশেন্ট যদি টার্মে হয়ে যায়, টার্মে এসে যায়, তাহলে তুমি কেন পেশেন্টটাকে আবার কনজারভেটিভ ম্যানেজ করবে? ইউ অ্যাক্টিভলি ম্যানেজ, ডেলিভার দ্য বেবি, mother will be okay, baby will be okay. Suppose patient is labor, there is a there is a you cannot extend the pregnancy as the patient is labor, you will have to terminate. And if there is a fetal death already fetal death, immediately terminate the patient for patient and patient. And suppose there is a, in spite of conservative management, bleeding is not in control, but there is a patients are anxiety, you will have to do that. This is the 4 conditions in the antepartum hemorrhage. It is irrespective of the APH and the placenta previa, abruptio placentae, you will have to terminate the pregnancy. These are the 4. So if a short note is given 4, we write down the 4 causes of the termination of the pregnancy in the APH or placenta previa. So you will have to write these 4 things. This is important. Macafee regime component. What is that? Bed rest, adequate nutrition and hematinic, to watch for any vaginal bleeding, examination of the vulval pad bleeding, and physical and obstetric examination of mother routinely, to monitor fetal condition clinically by USG at 2 to 3 weeks. তোমার উদ্দেশ্যটা কি? যে পেশেন্টটাকে একটু এক্সটেন্ড করব, এর মধ্যে আয়রন, ফলিক অ্যাসিড আরও দেবো ঠিকঠাক, আর যদি দরকার হয় পেশেন্টকে কখনো ব্লাড দিতে হতে পারে, এবং আল্ট্রাসাউন্ড করো রুটিনলি, যাতে অ্যাটলিস্ট 37 উইক্সের কাছাকাছি যায় আর ম্যাচুয়ার বেবি পাবো, হেলদি মাদার পাবো। When to deliver in placenta previa? Usually 36 to 37 weeks of pregnancy, and 34 to 36 weeks pregnancy when there is a history of vaginal bleeding or associated with the risk factors for the placenta previa. And in morbidly adherent placenta, delivery is recommended much earlier. Because morbidly adherent, if there is a bleeding occur, that is very dangerous thing, and cesarean section is very difficult. So you will have to do elective cesarean section in that case, so that the senior staff, anesthetists and senior obstetricians are present. Mode of delivery in the placenta previa, I already said, cesarean section is almost the rule, mode of delivery. But rarely the vaginal delivery by ARM, the type 1 placenta previa, that is the type 1 placenta previa, placenta is low, rarely it can do the, in case of type 1 placenta previa. Bleeding less, fetus condition good, and other observations favorable. Placenta previa, that is the cesarean section you see, that is the cesarean section is done, cesarean section. And third stage liver, active management of the third stage liver. Active management are always routinely done, and you must have to do active management. Active management main component is the oxytocin after the delivery of the fetus. 10 units, usually IM oxytocin. This is the main component of the, and control contraction is the vaginal delivery. That is active. And strong vigilant at the APH, both region, there is PPH, so patient, there is a chance of PPH, you remember. Management of the abruptio placentae is the same type of management, but it is a more aggressive management in aggressive placentae. You can see, they admit the patient and manage at hospital, not at the home, And resuscitation and make IV drip, same, blood diffusion, investigation, complete hemogram, coagulation profile. Here coagulation profile is more important. There is a chance of DIC. And urine is set for routine and arranged for sonography, maternal and fetal condition mostly closely, CVP monitoring, central blood, venous pressure monitoring, whether it is becoming less, that is very important, and hypotension, features of hypotension. Then definite obstetric management for pregnancy is planned, abruptio placentae. And as soon as the placental abruption is suspected, action should be swift and decisive, resuscitation, resuscitation and delivery. So placenta previa, abruptio placentae, delivery is the answer in abruptio placentae. And when to terminate, immediate termination is the rule, that is the aim. And role of expected management is less. মনে থাকবে তো যে প্লাসেন্টা প্রিভিয়াতে আমাদের কনজারভেটিভ ম্যানেজমেন্ট দিতে পারবো ঠিক ম্যাচুরিটি, আর অ্যাব্রাপসিও প্লাসেন্টাতে আমাদের ম্যাক্সিমাম করতে হবে, যেটা খুব মিনিমাম কেসে কনজারভেটিভ, মেজরিটি হচ্ছে যে টার্মিনেট করতে হবে, মেজরিটি টার্মিনেট। এবার মোড অফ টার্মিনেশনটাও ডিফারেন্ট, আর সিজারেন সেকশনের মোড অফ টার্মিনেশনটা কি? cesarean section. Antepartum hemorrhage due to placenta previa is the cesarean section. In abruptio placentae, the vaginal delivery with the artificial rupture of membranes plus oxytocin. Some cases, suppose severe abruption, os closed, you cannot wait. That is the indication of cesarean section. That is the indication of the cesarean section. But more, this is the principle of management. But there is sometimes the cesarean section is needed. This is the ARM. ARM is the Cockard's artery force. I think all of you know identify the Cockard's artery force. Artificial rupture of membrane is done by the finger. Artificial rupture of membrane, and then oxytocin is given. That is the Cockard artery force. These obstetrics few instruments. This is one of the instruments. Cockard's artery force. You say the cord clamping and the two indication, two use. Cord clamping and the ARM, artificial rupture of membrane. And this is the process of the artificial rupture of membrane. Abruptio placentae, the vaginal delivery. Abruptio placentae, the vaginal delivery. The main is the vaginal delivery. Mode of delivery in abruptio placentae, reveal type, patient labor, that you see, artificial rupture of membranes plus oxytocin, and patient not in labor, more than 36 weeks, ARM plus oxytocin. Patient not in labor, less than 36 weeks, bleeding continues, ARM oxytocin. Bleeding stops, and there is no concealed bleeding and small hemorrhage, you can do the conservative minimum. And concealed type, ARM plus oxytocin, irrespective of the period. Otherwise, the mother will die, baby must die, but the mother will also die. So, always there is a termination is the answer in case of abruptio placentae. And when the fetus is living and viable, vaginal delivery is not imminent emergency, cesarean section is performed by many. ওয়েট করতে গেলে তুমি দেখবে বেশি ব্লিডিং হচ্ছে ভেতরে, সেই জন্য cesarean section করা যেতে পারে। ম্যানেজমেন্ট অফ লেবার ইন abruptio placentae, ম্যানেজমেন্ট অফ দ্য লেবার, ক্লোজ মনিটর, as the more cases are the labor, close monitoring of labor is done, both maternal and fetal. Usually labor progresses well in abruptio following ARM, and following delivery of the baby, the placenta with retroplacental is expelled. You will see the retroplacental placenta and retroplacental cord is examined to assess the concealed blood, how much there is a blood loss. You will have to replace this is the, you can see the placenta and retroplacental cord. You can see this is the retroplacental cord, this is the placenta, and this is the retroplacental cord. So, there is too much of the retroplacental cord. So, hemoglobin will have to show and give the blood and blood product. Third stage onwards, active management of the third stage labor is done. Oxytocics are used, as I have said. Monitor the patient pulse, BP and urine output. Be vigilant for PPE. It is the adequate fluid, blood and blood products which are important to save the mother. Usual mode of delivery. Now, placenta previa, which one? Usual mode of delivery, bolo? Cesarean section, abruptio placentae, vaginal delivery. আচ্ছা একটা গল্প বলবো, গল্প মানে আমার এক্সপিরিয়েন্সের গল্প বলবো কতক্ষণ, টাইমটা দেখি। এই সাউন্ডটা আছে তো রে, হবে তো? এই মাদারের গল্পটা, এটা আমি যখন আরজি করেছিলাম কোভিড পিরিয়ডে, গল্পটা দেখ। মিসেস এক্স, 26 year old, third gravida, para 1+1, living is 1, 32 weeks, with vaginal bleeding in shock, was admitted in Arjikor Medical College Hospital on 12th August 2020 at 1:41 p.m. at the time of COVID, 2020, at the time of COVID, that patient. Admitted in shock. What is the period of gestation? 32 weeks. Admitted in shock. And patient was conscious but disoriented with feeble pulse and pulse rate 130 minutes, not recordable BP not recordable, and severe pallor with cold coming extremities. Per abdomen, এখানে দেখ, examination, uterus 34 weeks, tonically contracted, and tenderness plus FH is not localized. এখান থেকে তোর কি মনে হয়, কি ডায়াগনোসিস ক্লিনিক্যালি কি মনে হয়? পেশেন্ট শকে আছে, ইউটাসটা টনিক্যালি কন্ট্রাক্টেড, এফিজিস পাওয়া যাচ্ছে না, কী ভাববি? অ্যাব্রাপসিও প্লাসেন্টি, জোরে বল অ্যাব্রাপসিও প্লাসেন্টি। আচ্ছা, এইবারে ওর হাইপার টেনশন থাকার কথা, কিন্তু নেই কেন? যেহেতু ওর ব্লিডিংটা বেশি হয়ে গেছে, সেই জন্য ও দেখ পেশেন্টের হাইপোটেনশন। আল্ট্রাসাউন্ডে দেখা যাচ্ছে যে নো কার্ডিয়াক অ্যাক্টিভিটি অফ দ্য ফিটাস অ্যান্ড রেট্রোপ্লাসেন্টাল কর্ড, দ্যাট ইজ এ রেট্রোপ্লাসেন্টাল কর্ড, And PB examination was 6 centimeter, and cervix thick, blood stain like other investigations same. এখানে আমি কি ট্রিটমেন্ট করবো? 3 সেন্টিমিটার অনলি, পেশেন্ট অলরেডি শক আছে, ওকে আমাকে ইমিডিয়েট ডেলিভারি করতে হবে। আমি যদি নর্মাল লেবারের জন্য ওয়েট করি, একটা তো টাইম আছে সেকেন্ড মানে ফুল ডাইলেশনের, দ্যাট ইজ দ্য অনসেট অফ লেবার টু ফুল ডাইলেশন, সো দ্যাট mother cannot be cannot tolerate. So we take about the decision of the cesarean section. Resuscitation, parallelly resuscitation with blood and blood product done, and decision of the immediate termination taken, emergency LEC is done. You can see the intraoperative finding, LEC was done, and intraoperative findings, cubial uterus. A fresh stillborn baby 1.630 delivered stillborn baby, and 2 to 2.5 liter retroplacental cord. Total blood কত থাকে একটা হিউম্যান 5 লিটার, তো তার হাফ বেরিয়ে গেছে ওখানে, তাই না? অ্যান্ড ডায়াগনোসিস অ্যাব্রাপশন প্লাসেন্টি উইথ ইন্টারওটেন্ট ফিটাল ডেথ, দ্যাট ইজ ডায়াগনোস। এটা চিনতে পারছিস, কুবেলিয়ার ইউটার, হ্যাঁ ওই পেশেন্টারই। আচ্ছা, এই দেখ বেবিটা, এই যে বেবিটা দেখ 1.63 কেজি, জাস্ট তখনই ডেথ হয়েছে, ইন্টারওটেন্ট ডেথ। কত ক্লস দেখি, 2 to 4 retroplacental cord is the placenta, a placenta. Immediate postoperative period, patient could not be extubated, কারণ পেশেন্ট তো শকে ছিল, তো এক্সটুবেট করা যায়নি, ওকে ভেন্টিলেটরেই মানে এইচডিউতে পাঠানো হলো, এইচডিউ ল্যাটার অন সিসিইউ। ইন ইমিডিয়েট পোস্টপারেটিভ পিরিয়ড পেশেন্ট ওয়াজ হ্যাভিং ইনক্রিজ বিপি। কেন বিপিটা ইনক্রিজ করলো? বেসিক্যালি হি ওয়াজ প্রিএক্লাম্পসিয়া। যার জন্য যখনই আমরা ব্লাড রিপ্লেসমেন্ট করে দিয়েছি ভলিউম, তখন বিপিটা খুব হাই হয়ে গেছে। এবার বিপি হাই হলে কী হবে? দেয়ার ইজ এ চান্স অফ এক্লাম্পসিয়া, দ্যাট ইজ অ্যানাদার কমপ্লিকেশন এক্লাম্পসিয়া। হ্যাঁ, অ্যান্ড ট্রিটেড উইথ ইঞ্জেকশন ম্যাগসাল্ভ। ম্যাগসাল্ভ কেন দিয়ে হলো? ম্যাগসাল্ভের ইউজ কি? একটা হচ্ছে যে প্রিভেন্ট দ্য এক্লাম্পসিয়া, সিভিয়ার প্রিএক্লাম্পসিয়াতে, এটা সিভিয়ার প্রিএক্লাম্পসিয়া টু প্রিভেন্ট। আর একটা হচ্ছে এক্লাম্পসিয়া। আদার টু uses in obstetrics, one is the tocolytic and is the neuroprotective. The 4 uses in Magsalve in obstetrics. 4 is, it is a short note, 4 uses of Magsalve. Treated with Magsalve and antihypertensive, and again developed severe hypertension. যখনই দেওয়া হলো দেখা গেলো যে আবার হাইপোটেনশন ডেভেলপ করছে। এই যে ড্রাগ অফ অ্যাডজাস্টমেন্ট এবং মনিটরিং ইন দ্য সিসিউ ইজ ভেরি ইম্পর্টেন্ট। পেশেন্ট স্টার্টেড হ্যাভিং ফিচার্স অফ দ্য AKI, রেনাল ফেলিওর হয়ে গেল, ওরা বললাম রেনাল সব কিছু হয়েছে, renal shutdown, features of the DIC with HELP syndrome also, HELP syndrome. Management continued with daily dialysis, broad spectrum antibiotic, platelet PRBC and FFP transfusion. Suffered cardiac arrest. হঠাৎ করেই ভালোই ছিল সব কিছু, হঠাৎ করে কার্ডিয়াক অ্যারেস্ট হয় 5th ডেতে, বাট রিভাইভড, কার্ডিয়াক অ্যারেস্ট রিভাইভড অ্যান্ড এক্সটুবেটেড ফাইনালি অন পোস্ট অপারেটিভ ডে 16। এতদিন ধরে ভেন্টিলেশনে ছিল, 6 দিন থেকে, তারপরে ওই অতদিন ধরে ভেন্টিলেশনে ছিল পেশেন্টটাকে, আফটার 16 days এক্সটুবেট করে হিমোলাইটিস ডিজিজ কন্টিনিউ, রেনাল ফেলিওর হয়ে গেছে অ্যান্ড রেনাল ফেলিওর। সো এই যে পেশেন্ট পোস্ট অপারেটিভ পিরিয়ডে ডেভেলপ, এই শুয়ে এই যে এটা একটা ইম্পর্টেন্ট কমপ্লিকেশন, যে একই পশ্চারে যদি থাকে দ্যাট ইজ এ চান্স অফ প্রেসার, দ্যাট ইজ দ্য প্রেসার মানে ডেভেলপ প্রেসার সোর, বেড সোর হয়ে যায় পেশেন্টের। যাই হোক, আমার টিমটা খুব ভালো ছিল, যা পোস্ট গ্রাজুয়েট এবং ইন্টার্ন যারা ছিল, ওরা কিন্তু ডেলি ড্রেসিং করে আস্তে আস্তে পেশেন্টটাকে বেডশোরটা ভালো হলো, পেশেন্টটা ক্রমে ভালো হলো অ্যান্ড গ্র্যাজুয়ালি রিকভার্ড অ্যান্ড পেশেন্ট ওয়ার ভেন্টিলেশন ফর 16 days অ্যান্ড সি আন্ডার টোটাল 23 হিমোডায়ালিসিস, 23টা হিমোডায়ালিসিস পেয়েছে কিডনি ফেলিওরের জন্য, অ্যান্ড রিসিভ 53 ব্লাড অ্যান্ড ব্লাড উইথ 53 blood and blood product on a PRBC 20 at the time of COVID, and the patient finally was discharged on 5 Jose, আর অগাস্টে ভর্তি হয়েছিল, 2 মাস বাদে আমরা ছেড়েছিলাম, and admission in stable and 55 days of admission in stable condition, normal and thanks to the husband, ও আমাদেরকে খুব করেছিল, আমরা অভয় দিয়েছিলাম, চেষ্টা করছি, ভীষণ মানে পেশেন্টলি ডিল করেছে, যে পেশেন্টটা এত খারাপ ছিল এবং ফুল টিম দেখেছে। অ্যান্ড অ্যাকচুয়ালি কুডোজ টু মাই টিম, আমার টিম মানে কন্টিনিউয়াস, ওই যে আমি থাকতাম পড়ে থাকতাম, পড়ে সব এরা সব পোস্ট গ্রাজুয়েট ইন্টার্ন দেখেছো অ্যাট দ্য টাইম অফ দ্য কোভিড, কুডোজ টু মাই টিম। ওরা পোস্ট গ্রাজুয়েট এখন ওয়েল এস্টাবলিশ, তারা অনেকের 2020 সালের কেস এটা। হ্যাঁ, আচ্ছা, এই পেশেন্টটা আমরা আমার কেস রিপোর্ট করা হয়েছে যে এরকম একটা আনইউজুয়াল কেস এরকম ডেভেলপ করলো, হ্যাঁ। নো কেস ইজ লস্ট ইন মেডিসিন, হ্যাঁ তো, নো কেস ইজ লস্ট ইন মেডিসিন। বুঝলি তো, যে এটা মারা যাবে ভালো হবে না এটা নয়, তুমি শেষ পর্যন্ত পেশেন্টটাকে দেখবে যে ইউ ক্যান কিন্তু এফোর্ট, এটা যদি একটু নেগলেক্ট করা হতো বা একটু কোথাও কন্ট্রোল করা হতো বেঁচে যেত। হ্যাঁ, পার্সিউ ইউর গোলস ইভেন ইন দ্য ফেস অফ দ্য ডিফিকাল্টিস। হ্যাঁ, পার্সিউ গোল। শুনতে পাচ্ছিস? হ্যাঁ, দেখ মেসেজটা দেখ আজকের ক্লাসে। অ্যাব্রাপসিয়া বুঝলি তো কী জিনিস, কিন্তু পেশেন্টকে চেষ্টা করলে বাঁচানো যাবে। এবং প্রত্যেকটা হেমারেজ, এভরি ডেথ ফ্রম হেমারেজ ইজ এ প্রিভেনশন। হ্যাঁ, এভরি ডেথ ইজ প্রিভেন্টেবল। এত মাদার আমরা দেখি যে আগে মারা যেত, এখনও তো মারা যায় না, কিন্তু তবুও মারা যায়। হ্যাঁ, হেমারেজে তবুও মাদার। থ্যাংক ইউ। কোনো কোশ্চেন থাকলে বল, আমি টাইমে শেষ করে দিই।